major importance.
Thank you. I'd like to thank the moderators and the Society for allowing me to present this. Just as a disclosure, Medtronic did provide us the generator for use on these patients, as well as some writing assistance. The objective of the study was to assess whether there was any added benefit in adding the radio frequency saline-coupled bipolar device called the Aquamantis into open thoracic cases, and comparing it with standard technique using electrocautery. In a single surgeon retrospective review of 28 patients over a 6-month interval, and medical records were reviewed for parameters which included time for chest tube removal, ambulation, time to ambulate, discharge, estimated blood loss, and postoperative pain using a 10-point visual analog scale, which was correlated with analgesic usage and written surveys postoperatively. Bipolar protocol was to pre-treat areas that we would otherwise just divide using standard electrocautery, using the Aquamantis in tissue as well as vessels less than 5 millimeters in size, prior to actually dividing them in an attempt to seal the tissue, as well as hopefully prevent some excess charring which may occur with standard electrocautery. As I mentioned, 28 patients, 16 of them were female. The average ages were 67 in the bipolar sealer arm versus 75 in the control. And we looked at both intraoperative estimated blood loss measured through the suction canister, as well as the initial chest tube output, as well as overall chest tube output. And we found that the difference was intraoperatively of 50 cc's in the pretreated arm compared with 310 cc's, and total chest tube output of 125 cc's compared to 800 cc's. Time to chest tube removal was shortened down to 1 day compared to 3, and interestingly enough, I think the strongest indicator came in the form of pain. Most of the patients reporting a pain index of 3 compared to 7, and that they ambulated slightly sooner, and the time for discharge seemed to be quicker. And so we concluded that there was some improvement in recovery outcomes with the adjuvant use of the Aquamantis prior to division of the tissues, but the limitations of the study obviously are its small size, retrospective nature, and single center, single surgeon protocol, and a larger prospective study is really needed to confirm the results. Thank you.
Thank you. Any questions? I was just, I don't understand how this bipolar saline, maybe you didn't get to that in your talk, but how does this work differently than what you do normally?
Sure. Normally on standard cases, the thoracotomy just use traditional Bovie to divide the tissues. Clips on larger vessels, obviously, or ties. But the Aquamantis is a saline-coupled bipolar device that has 2 prongs, and you basically paint the area or go around the area, treating the tissue prior to division. And it seemed that helped to potentially seal the tissue and the smaller vessels prior to dividing them.
Do you think that limited any way in the way that you were dissecting? So if you're having to paint this area ahead of time, as opposed to if you're taking, say, lymph nodes directly off of the trachea, how do you? It's limited in the sense that you have to be able to get access to the area. For small, minute areas, it's probably not indicated. But for, say, chest wall resections, where you're going to resect the area, you just do the broad strokes and then divide. Some Ivor Lewis's, I've used it on, areas that you would otherwise have access to.
For a nice presentation. All right. We've been using this for, Netu Sarkaria from New York. We've been using this for some time and found it very useful in sort of exactly broad areas with raw surface, such as an extrapleural pneumonectomy or decortication or something like that. I guess my question, which has partially been answered already, is where have you been seeing the blood loss? Is it during the subcarinal lymph node dissection? What were the nature of these operations? And how have you been using it differently to alter the way you use electrocautery? Where I would
Sure.
think that most of us really do cauterize whatever vessel we're taking first, not simply just cauterizing across it.
Sure,
Yes.
no, absolutely. I think that the main benefit was in areas where it was more diffuse, larger areas, decortications where you had excessive peeling, densely adherent tissue to the chest wall, where that broad surface was oozing, as opposed to just kind of try to paint the whole thing with a standard cautery. It was treated with this. Chest wall resections prior to division of the tissues. Not so much for the mediastinal nodal dissection. Thank
Could you use that for resection, atypical resection of metastasis through the parenchyma? Is that something to similar to a laser to seal the tissue around it, and so you would have nothing more to do after taking out the metastasis?
Well,
No.
yes and no. You can pre-treat the area, but the device doesn't actually cut. You have to cut either with a scalpel or standard cautery. So you can pre-treat the area, but you're not using it to resect it.
But if you pre-treated this area of the periphery, for instance, and then you cut, you excise, would you have to oversew or not?
No, not in the ones that I did.
Thank you.
Thanks.
Just real quickly, thank you very
Sure,
much.
thank you.
We have a coffee break